Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Today, I'm talking about one common and one very rare cerebrovascular disease with Dr. Haydn Hoffman. He's an assistant professor of neurosurgery at Upstate. Welcome to the Informed Patient, Dr. Hoffman.
Hello, thanks for having me.
You spent 7 years at Upstate while you were doing your neurosurgery residency, and then you went to Tennessee for a cerebrovascular endovascular fellowship, and now you're back as a neurosurgeon specializing in open and endovascular treatment of cerebrovascular disease. When you decided on a medical career, what drew you to neurosurgery?
I've always been fascinated by the brain, and at the same time, I liked working with my hands and fixing problems rather than treating chronic diseases. And that's what drew me to surgery. So between those two interests, I decided on neurosurgery. And I just think the brain physiology and anatomy are just incredibly interesting. And neurosurgery is a constantly growing field with new technology being introduced frequently. So I chose neurosurgery based on those things.
Well, I wanted to talk to you about a paper that you were a co-author for, something I've never heard of before called moyamoya disease. Now, this was in the journal Neurology this fall. Can you explain what moyamoya is?
Sure. It's what we call a progressive vaso-occlusive disease. That just means narrowing of blood vessels, and progressive meaning it gets worse over time. And it involves the internal carotid artery. That's one of the main blood vessels that supplies the brain. It can also involve the anterior and the middle cerebral arteries, which are branches of the internal carotid artery. And those are some of the most important blood vessels that supply the brain. Oftentimes, it involves both sides of the brain. It's not inflammatory. It's not related to atherosclerosis. Basically, it involves proliferation or enlargement of the inner layer of the blood vessel. So the blood vessels in the body have several different layers, and this moyamoya disease involves the inner layer of the blood vessel. It was first described in the 1950s in Japan, and then later described and actually named in the 1960s.
So what is the incidence in America? I know it's pretty rare, but how many people might be diagnosed with this in a year?
Right. So it's very rare in the US. As I said earlier, it's more commonly seen in Japanese patients. So in Japan, it's roughly 10 patients per 100,000. In the US, the higher range of estimates is around 0.75 per 100,000. And that was the rate or the incidence that was described in the paper that we published. But that was actually on the higher end. There are several other papers that cited as being even lower.
Do we know what causes this? And is it something people are born with, or do we even know that?
Well, unfortunately, we don't have a great explanation. In Japan, there have been several familial or genetic links that have been described. And in Japan, it's more commonly seen in families, meaning there may be a genetic component to that that's less commonly seen in America. But beyond kind of what's been described in Japan, we don't have a great explanation about why it happens or what causes it to get worse, I should say.
Now, how would a person find out they have this? Would there be symptoms that a person would become aware of?
Right. So it's really just diagnosed based on imaging. So any kind of imaging of the blood vessels, whether that's a CT angiogram, an MR angiogram, usually those are the first studies that get performed. And then we as neurosurgeons often perform a catheter angiogram to formally diagnose it. In terms of the warning signs or signs and symptoms, it's really just your typical stroke or TIA, transient ischemic attack symptoms and things like arm and leg weakness, facial droop, speech problems. But patients can also present with hemorrhages or bleeds in the brain, and that might present with a severe headache, sudden loss of consciousness. And in adults, we see the hemorrhages more common than the ischemic stroke symptoms. So it's usually in adults more commonly a bleed rather than a lack of blood flow. But moyamoya disease can present either way. And then the last thing would be a seizure that sometimes these patients present with.
Is there any treatment?
The treatment at first is usually medical, meaning we put these patients on an aspirin to kind of reduce the secondary effects, the ischemic strokes that can be caused by this progressive narrowing. The other treatment where I get involved is the surgery. And there are different types of surgeries that can be performed, but the goal is to augment the blood flow getting to the brain to kind of bypass the narrowing that's happened in the internal carotid artery. And typically we use an artery in the scalp and connect that in an artery in the brain past where the occlusion is or where the narrowing is, and that increases the blood flow and hopefully prevents further strokes.
So that's like a bypass, it sounds like.
Exactly. Yeah, it's a bypass surgery.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate neurosurgeon Dr. Haydn Hoffman. Now let's talk about a condition that's more common that you've already mentioned, stroke, but specifically ischemic stroke when a blood clot blocks an artery in the brain. 4 years ago, you co-authored a paper in the journal Stroke that looked at the increased use of 2 hospital treatments for ischemic stroke. Can you walk us through those 2 treatments?
Sure. The treatments you are alluding to are what we call thrombolysis, or breaking up a blood clot through medications given through the IV. And mechanical thrombectomy would be the other one, which is a endovascular procedure that neurosurgeons perform to actually take the blood clot out of the brain. The thrombolysis was first described back in 1995, or I should say it was kind of established as an effective treatment back then with a medication called TPA, which is given through the IV and breaks up the blood clots in the brain. Since then, we've progressed to using a medication called TNK, or tenecteplase, which is a little easier and faster to administer through the IV, but it works exactly the same way. And essentially, these medications activate an enzyme that breaks down blood clots, and this causes the blood clot to dissolve and hopefully reopen the occluded blood vessel and restore flow to the brain. The other procedure or treatment you mentioned was mechanical thrombectomy. And so this is a invasive procedure performed in the IR suite using X-rays and contrast. But typically the femoral artery in the groin is accessed. We place a large catheter through the arteries up to the neck, and through that we place smaller catheters that actually go into the brain. And throughout this whole process, we're taking pictures with the X-rays, we're injecting contrast to see where we are and where the blood vessel occlusion is. Once we're up into the brain with small catheters, we have various ways of getting the blood clot out. We can either aspirate it out or deploy a stent and pull it out.
So how do you decide when a person comes in who's having an ischemic stroke, which of these procedures is going to be best for them?
Well, like you alluded to, the first step is to establish that it is an ischemic stroke and not a hemorrhagic stroke, because giving the TNK or TPA would obviously make a hemorrhagic stroke much worse, since that's a bleeding problem, and TPA and TNK break up blood clots. At that point, if it's determined that the patient is having a stroke and it's an ischemic stroke, we look at various inclusion criteria for the thrombolysis medication, the TNK. The most limiting one, I would say, is that the patient had to have had symptoms within the last 4.5 hours to be eligible for the TNK. And that's because there is a small but clinically significant risk of causing a bleed in the brain when we give this, even if it is just an ischemic stroke. And so patients with strokes are screened for TNK eligibility. There are several other potential contraindications or reasons we wouldn't give TNK. For example, if the patient has had a recent surgery, if they have very severely elevated blood pressure, if they have some other bleeding somewhere else in the brain, like, for example, the GI tract, if they're prone to bleeding, or if they use blood thinners prior to presentation. So after screening for TNK, we kind of simultaneously screen for whether or not the patients can undergo a mechanical thrombectomy. And the way we determine that is as part of the stroke protocol or stroke code that we activate, patients get blood vessel imaging with a CT scan. And if there is a blockage that we can see on the CT scan of a large blood vessel, then oftentimes those patients will go for mechanical thrombectomy. And that can be done in addition to the TNK. They're not mutually exclusive. When mechanical thrombectomy started gaining a lot of traction, and around 2015, we were fairly selective about which patients could actually get a thrombectomy. For example, they would often be limited to patients who presented within 6 hours. But now we've really extended that time window out. We found lots of patients benefit, even sometimes performing these procedures up to 24 hours after patients have presented.
How successful are these treatments, either alone or when you use them together?
Well, it depends on the type of blood vessel blockage. TNK is less successful for blockages of large arteries in the brain. That doesn't mean we don't give it in those cases, but those are patients who are really going to be better candidates for thrombectomy. And in terms of thrombectomy success, we define success as recanalization or getting the blood vessel open. And in those cases, thrombectomy is usually successful in greater than 75% of cases. So we define success as a certain grade of recanalization. We use a cutoff, and that has been commonly utilized in the literature. And based on that definition, 75+% of patients were able to get the blood vessel open. Unfortunately, there are a small proportion of patients who we aren't able to get the blood vessel open no matter how hard we try. But fortunately, with improved endovascular technology, that subset is getting smaller and smaller. Now, if you look at the clinical trials evaluating mechanical thrombectomy, the success rate is defined as functional independence at 90 days after the procedure, meaning can the patient take care of themselves and do all their normal routine daily activities by themselves. And that success rate is slightly lower, more in the 50 to 60% range. So sometimes, even though we're able to get the blood vessel open, patients don't always become functionally independent.
Does some of this depend on the speed with which the patient or their family members recognize that they're having a stroke and call 911 and get them to the hospital?
Absolutely. So time is critical in acute strokes. You hear the phrase time is brain, and that is really because as time goes on, more neurons or cells in the brain are dying. Time is critical. It is also influenced by patient-related factors, things like patient's age, their collateral circulation in the brain, meaning are they still able to get some amount of blood flow to that starved area of brain through other pathways? And that's different in all kinds of different patients.
Before we wrap up, can we go over the warning signs of a stroke? And are they the same for an ischemic stroke as for a hemorrhagic stroke?
Sure, there's a lot of overlap between ischemic and hemorrhagic stroke in terms of presenting symptoms. We talk about some of the common stroke-like symptoms, such as facial weakness on one side, arm and leg weakness on one side, trouble talking, sudden loss of vision, and you can have any of those with a hemorrhagic stroke as well. But we see other things with hemorrhagic stroke, such as severe sudden onset headache from increased pressure in the brain, nausea and vomiting, and also things like seizure.
I see. Once someone survives a stroke, what is done to help reduce the risk of them having another stroke?
It's a good question. Well, in every stroke patient, they have a workup to determine what caused the stroke. That workup is typically led by the vascular neurologist rather than the neurosurgeon. But that is really the critical first step, is trying to find what caused the stroke so that we can do a intervention or a medication to reduce that risk going forward. And there's several other kind of universal treatments in any patient that has a stroke that go forward to reduce the risk of further strokes. Things like making sure the patient is started on a statin, a medication for their cholesterol, making sure that blood pressure is well controlled, that diabetes is well controlled, so on.
Well, that's good to know. Dr. Hoffman, thank you so much for making time for this interview. I appreciate your time.
Absolutely. Thank you for having me.
My guest has been Dr. Haydn Hoffman, an assistant professor of neurosurgery at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.